Good evening. It's certainly a great feeling to be here. Thanks all concerned for this opportunity. I'm Dr. Shahida Alam is going to present the triple negative breast cancer data from Bangladesh. Before get started, I want to make a point clear. Though most of the patients' data were collected from National Institute of Cancer Research and Hospital, but this patient had their radiotherapy at Cancer Institute, having their surgery and systemic therapy either at National Institute or different centers all over the country. So it represents the patient profile and the treatment trends across the country. Let's get started. So how much is the Bangladesh breast cancer burden? According to the Globocan 2020, it is the most common malignancy among women with a prevalence of 19% in Bangladesh. And the hospital-based cancer registry report 2015 to 2017 published by National Cancer Institute of Research and Hospital shows breast cancer is the topmost cancer in female, accounting for 30.4%, and second most common malignancy when both sexes combined, that is 14.1%. Among 35,370 cancer patients treated in NICRNH from January 50 to December 17. So regarding our today's focus, what is the magnitude of TNBC in Bangladesh? There is no robust data to authentically say, but there are two publications that showed it was 9%. This publication was published in 2010, and another showed it was 20 to 26.6% that was published in 2016. In my small series of randomly collected data of 500 breast cancer patients with known receptor status, TNBC was 168, that is 33.6%, pretty high. So an observational study was done. We did retrospective review of medical records of 221 TNBC patients who attended radiation oncology department of NICRNH and two private hospitals for treatment and follow-up from January 2019 to July 2021 were performed. Clinico-pathological profile, treatment trend, and short-term outcome were evaluated. Regarding the result, 68% patients got their treatment from NICRNH and 32% patients from private hospitals. Among them, one patient was male, and the median age of diagnosis was 40 years, plus minus standard deviation of 10.843, and the age range was 22 to 74. It was invasive ductal carcinoma, which is most frequently occurring histology, that was 94.5%. Others are invasive lobular carcinoma, medullary carcinoma, and papillary carcinoma. Grade 2 were the most frequently occurring grade, followed by grade 3. Patient presented with a lump in the breast with a mean tumor size of 3.73 cm with a standard deviation of 1.86, and we have got a maximum tumor size of 13 cm. 104 patients had pathologically positive axillary lymph nodes, out of which 69 patients had 1 to 3, 59 patients had 1 to 3 lymph node positive, 33% patient had 4 to 9 lymph node positive, and 8% patient had more than 10 lymph node positive. Most of the patients underwent upfront surgery, so the staging is basically pathological staging. And then 5.9% of the patient was in stage 1A, and most of the patient remained in stage 2 and stage 3. And 5 patients presented with upfront metastasis. And unfortunately, 38% of the patient remained unstaged, basically due to inadequate number of axillary lymph nodes in the specimen. And in some cases, there is no information about the tumor site due to unplanned lumpectomy. So when we analyzed the pathological specimen, it showed that less than 5% lymph nodes were present in 13% of cases, and in 40% of cases, 5 to 10 lymph nodes were present in the pathological specimen, and in 47% of cases, more than 10% lymph node was positive. Moving to the treatment side, 51 patients received neoadjuvant chemotherapy. Most of them were LABCs, and the full chemotherapy cycle were given before surgery for 27 patients, out of which 5 patients had complete pathological response. AC followed by paclitaxel was the most frequently used protocol, followed by AC, which was given in a sandwich fashion with paclitaxel after the surgery. 6 patients got AC followed by paclitaxel and carboplatin. Regarding the surgery, 53.4% patient underwent modified radical mastectomy, and 17.6% patient had mastectomy with incomplete axillary clearance, and 7% patient had mastectomy without any axillary surgery. 14% patient underwent breast conservation surgery with axillary dissection, and 3% patient had breast conservation surgery with sentinel lymph node biopsy, NCT or palliative chemotherapy. Here the same thing, the AC followed by paclitaxel was the most commonly used protocol, followed by AC docetaxel and FAC. And 14% of patients received platinum in the adjuvant setting. And when we add all together, it shows that about 88% of patients received taxane either in adjuvant or neoadjuvant setting. And I think this is an achievement. Regarding adjuvant radiotherapy, 84% patients received adjuvant radiotherapy, out of which 6% was conventional fractionation, that is 50 grain 25 fraction, and 94% cases that was hypofractionation, that is 40 grain 25 fraction. And this 30% cases, this is done by 3D CRT, and rest, that is 70%, this is 2D planning. And 100% cases, the treatment delivery was done by linear accelerator machine. The time interval between the date of diagnosis and treatment completion, with a mean of 9.8 months and a standard deviation of 2.6 to 8. And it was statistically different between the NICRNH and private hospitals. It is evident that treatment duration is quite long in the government hospital, and that has become even worse during this pandemic due to repeated lockdown. And because government hospital is the only place to go for the less affordable. So we have a huge queue, so the treatment time is always very long. So in private hospital, it is about 8.19 months, and in government hospital, it is about 10.687 months. When we did the outcome analysis, we failed to reach out to 24 patients, and among rest of them, 76% patient had no relapse, and 16% patient relapsed either locally or distally, and 6% patient progressed on treatment. Brain was the frequent site of metastasis, accounting for 25%, followed by node, lung, and bone. 14 patients had local recurrence with or without distal metastasis. Regarding the disease-free survival, it was median disease-free survival was 13 months, which was again statistically significantly different between NICRNH and private hospital. In NICRNH, it was a mean of 14.15 months with a standard deviation of 11.874. And for private hospital, it was 23.97 plus minus 21.97. When we did the survival outcome, we found 78% patients were alive, 7% patients were alive with disease, and 15% patients were died. Simply put, beside TNBC is an aggressive subtype, there are factors that are associated with adverse outcome, like advanced stage of presentation, inadequate surgery from some patient, unusually long total treatment duration, NSCT in early stage, and treatment escalation have not been adopted enough. Yes, we have been struggling with a lot of issues, with lots and lots of issues. Sometimes I feel helpless, get frustrated, but then these people gave me hope, strength. This lady was diagnosed as right breast cancer in 2013 at the age of 25, HER2 type, treated without anti-HER2 therapy. She was again diagnosed as left breast cancer in 2018 with 27 weeks of pregnancy, TNBC, treated without anthracycline. So when this baby was born, his mother had already bilateral mastectomy. So there was no provision of natural food for him. 3 years have gone, still happy and healthy. So yes, we can fight with our limited resources and can win also. With this, I am ending here. Thank you so much for letting me sharing my experience with you. And if you have any question or query, I would love to clarify. Thank you so much.